Okay. No, I don't think you're wrong. I actually agree with most of what you guys said. In what world did it seem like a good idea to slurp a beverage into a microphone?
Well, I was thirsty. So, anyway, Matt, you were about to say something deeply insightful, I believe.
Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is as confused by the latest health study as I am in trying to do yoga. You guys yogas?
I heard Noga.
Yoga.
Noga.
No.
What's Noga?
It was on that thing that you heard on the internet where some people hear one thing and the other. I heard Noga.
Noga?
Yeah,
I heard Yanni.
I heard I don't know what I heard.
Pembrolizumab.
Okay. Well, I'm Matt Fox, professor of epidemiology and global health, and I'm here with Don Thea and Chris Gill from the Department of Global Health.
Hey, Matt.
Hello.
And we are here, as always, in the Boston University Godley studio. So, guys, I don't know, have I ever mentioned to you guys anything about population health exchange?
No,
I haven't told you about it.
What is that? Tell us.
Well, I will tell you, that is Boston University School of Public Health's resource hub for lifelong learning. You should check it out.
That's a great idea. We should have one of those at Boston University.
No, we do. And you can find out more at www.pophealthex.org.
Oh, that's using that internet thing.
Yeah.
Cool.
Type in
Why exchange?
exchange.
Yeah.
It's like a consignment shop.
Yeah, that's exactly what it is.
So you bring one thing in, you get another?
You bring in your old health and you get new health.
That's exactly what it is not. So it is a place, however, where you could find this podcast as well as many other population health learning programs and tools. And also just a reminder to everyone, we would love it if you would go onto Apple Podcasts and give us a rating. I always say iTunes, but I think it's Apple Podcasts technically. Is it, Nick? Yep, Nick's nodding.
It is.
All right. Or you can go to any other major podcast sites, and that will help people find us, and we would really appreciate it. Now on to the show. So today in our first segment, which is our Journal Club segment, we're going to look at a study that looked at the effectiveness of immunotherapy for treatment of lung cancer. Then in this, Don's giving me a look. Is it not immunotherapy? Did I say it wrong?
You're right.
No, it is. Absolutely.
Okay, you're just giving me a look, like maybe I had said something
look.
wrong. Then in the second part of our podcast, which is our deep dive segment, we're going to talk about whether it is okay to change your endpoints in a clinical trial and when it's okay to do so. And then in our third segment, which is our amazing and amusing, we will get into the things that just made us giggle or kept us going in our daily jobs. So let's get right into it with segment one. So we're going to get into an article that looks at the effectiveness of treatment for lung cancer. I just want to make sure I get this right.
Yes, it is lung cancer.
No, I know that part. Whether immunotherapy, in addition to standard therapy, is effective at treating lung cancer. You'll get into the details, but it's a specific kind of lung cancer. This was published in the New England Journal of Medicine with first author Lena Gandhi from the NYU Perlmutter Cancer Center in New York. The study was entitled Pembrolizumab.
Excellent.
Pembrolizumab
Very well done.
plus chemotherapy in metastatic non-cell lung cancer.
Non-small cell.
Non-small cell. Well, did I just say non-cell?
You did.
Non-small cell lung cancer. So, as always, let me give you some of the headlines on this one because this one made a big splash. So, Science Daily says, combination therapy doubles survival in metastatic lung cancer. The New York Times says lung cancer patients live longer with immune therapy. NPR says Merck immunotherapy drug shines in lung cancer study. And the Cape Cod Times, our very own local Cape Cod Times, I assume you guys are subscribers.
Yep.
Refers to this as the Super Bowl of lung cancer immunotherapy. And another one that I found interesting, WSYM TV, I don't know what that is, but says new treatment could, quote, melt away cancer. Don't know what that means or where it comes from. But there you go, some of the headlines on this study. So Don, I'm going to hand it over to you. Can you give us a breakdown of what this study was about and what they found, what they did?
Sure.
Why they did it?
Sure. So before I start describing the study, let me just give a little bit of a background on the cancer and the immunotherapy. The the cancer is a bad kind of lung cancer. It's called non-small cell cancer, but it really comprises the majority of the cancer, lung cancer that is diagnosed in this country and throughout the world, and is directly a result most of the time from smoking. And the 5-year survival for what we call stage 4, which means that the cancer has metastasized to different parts of the body, is about 5%. So it's a really, really bad cancer. And the standard therapy is chemotherapy using 2 agents. One is a platinum-based chemotherapeutic agent, which is not very effective and really quite toxic. And the other one is something we call an antifolate. What it does is it blocks folate metabolism, which affects the cancer cells in a greater way than it does affect normal cells. And cancer is notorious for being able to escape the effects of the immune system. In fact, that's probably why you get the cancers, because your immune system has somehow been tricked into not recognizing the cancer cells. And so what the cancer cells, in essence, do, they mutate and they sort of put on this invisibility cloak so that the cancer cells themselves are really not seen by the immune system. And there's this one sort of epitope, or this sort of antigen, this thing that is on the surface of the T cell, which is called PD-1. And
T cell meaning an immune cell.
Right. So T cell is the immune cell, the white blood cell in the immune system that is responsible for eating the cancer.
Okay.
So the T cell has this way of identifying the cancer, and the cancer a lot of times will develop a way of sort of blocking the receptor that the T cell recognizes to say this is cancer, this is not self. And there's the immunotherapy, in essence, is a way to block that blocker.
Got it.
Yeah,
It's like a double negative.
So it's like a double negative. So in essence, what this immunotherapy is doing is it's pulling off the invisibility cloak.
Got it.
And in essence, what these are monoclonal antibodies. So they're just proteins that have been designed to do exactly that. They bind onto this part of the cancer that deceives the immune system. So the hypothesis that these authors had was that a combination of chemotherapy and this immunotherapy in the setting of this kind of a cancer might actually have a pronounced effect. Because in essence, what you're doing is you're disrupting the cancer cells, breaking it into little pieces, and sort of generating more of that antigen to allow the immune therapy to work better, in essence. So that was the hypothesis. So what they did was they designed a double-blind phase 3 trial among 616 patients with metastatic non-small cell carcinoma. And none of these patients had prior treatment, and they were all stage 4. They all had metastatic disease, so a really bad prognosis. And it was a pretty straightforward design. There was the best alternative therapy, which were those 2 chemotherapeutic agents, and placebo, compared to those 2 therapeutic agents, plus this immunotherapy, pembrolizumab.
Pembrolizumab.
Right. So the patients were over 18. They had to have 1 measurable lesion. They had to have a tumor sample with the PD-L1 status measured.
What's
and the PD-L1 status is really the amount of that antigen on the surface of the cancer cell, because they've shown before that if the amount of the percentage of cancer cells with that particular antigen on their surface is greater than 1% or above 50%, even better, then this immunotherapy is very effective.
More likely to work.
More likely to work.
Got it.
So the trouble is that the number of patients with cancer of that type is really quite small. So the number of patients that can benefit from this immunotherapy is limited, very limited.
I see. So this doesn't pertain to everybody.
Correct.
Got it.
Well, that's what they were trying to address with this study, was that they were trying to expand the number of individuals who could benefit from the immunotherapy.
I see.
So in essence, what they're doing is they're trying to generalize this therapy. So the way they set this study up was it was at many centers. The assignment was 2 pembrolizumab enrollments versus to 1 placebo enrollment.
Yeah, they didn't randomize 50-50 like we have typically seen in most of the randomized trials. It was a 2-to-1 randomization where twice as many people got the
intervention.
The intervention compared to the best alternative.
Right, and then they stratified it by PDL1 expression score, really the number of the people with high expression of this particular antigen. They had
and those would be the ones who one would hypothesize would particularly benefit from this drug, correct?
Right, which is why they stratified, because they wanted to look at the effect in both the low risk and the high risk groups. And so what they had was they had a maintenance cycle where the chemotherapy would be given for 4 weeks and then 35 cycles of one arm or the other. Notably, if in fact the disease progressed in somebody who was in the placebo arm, as determined by an independent body, that individual was permitted to cross over and receive the intervention. And it turns out that they, in fact, didn't censor those crossover events. The assessment was tumor imaging at week 6, 12, and every 9 weeks until 48 weeks. And the endpoint was overall survival and progression-free survival.
So 2 what we would call very hard endpoints in terms of their clinical relevance.
Right.
This is not like looking at a CT scan and seeing whether the tumor got bigger by 2 centimeters or smaller by 2 centimeters or no change.
Right.
This is actual, like, how long do they live?
Yeah.
Which is an unambiguous bottom line.
Right. So the analysis was an intention to treat. They did Kaplan-Meier for endpoints, and they did Cox proportional hazard, sort of looking at the significance of the sort of the effect of one arm versus the other.
Look at the effects, not the significance.
The effects, right. Did I say that?
You did?
Look at the significance.
Yes. No.
And interestingly, the data that were presented in this paper were based on the first interim analysis. Now, all of the endpoints that we're looking at in this paper that we're following, in fact, are continuing to be followed because they're going to be following this cohort, I think, for probably many years. In terms of the baseline, it looked good, except for some slightly more men in the intervention group, 62 versus 53%, but all the other baseline factors looked basically balanced. 88% were current or former smokers. 63% had high PDL1. So those are the individuals who you would expect would respond to the immunotherapy. The median follow-up was 10 and a half months, and 41% of the placebo group ended up over this observation period crossing over to receiving the active therapy
Because they were doing poorly on the standard
because they
chemotherapy.
progressed, right. So there were 235 deaths at 12 months. 69% of the treatment group, the active treatment group, were alive, and 49% in the placebo group were alive.
Right.
The median overall survival was 11.3 months in the placebo group, and the median overall survival was not yet reached in the intervention group. So that means that half of them had not achieved the outcome.
They were still alive, in other words.
Right.
Yeah.
So the hazard ratio, which is sort of like the risk ratio, was 0.49. So the effect of the intervention was about double.
Yeah, about a 50% reduction in mortality.
Right. And then there were several subgroup analyses that showed an even greater effect. Women, interestingly enough, seem to have a greater effect, although the confidence intervals are very wide.
Come back to that. Yeah.
And also non-smokers. And interestingly, there was an effect even in the group of individuals who had low levels of this antigen.
Mm-hmm. Mm-hmm. Okay. So let me just clarify 2 things before we go on, which is I think I might have said something sort of misleading when I was asking you. So you're saying here they were trying to make this therapy available to more people, essentially, that previously it would have been available to some people, but it's a small percentage of the population.
Right.
I was worried that we were talking about something that's only going to apply to a very small percentage of the population with lung
exactly
cancer.
the opposite.
It's exactly the opposite.
Right.
So the idea here is to broaden the indications.
To show that it works in more people with lung cancer.
Use. Second of all, you said this was based on an interim analysis. So the interim analysis being the idea that with clinical trials like this, where we're concerned about the safety and effectiveness, that there is typically a data safety and monitoring board who looks at the data maybe sort of in the middle of the trial, or it could be at several times, and looks to see whether or not there is an effect early, earlier than we had anticipated, and then you might stop the trial early because it's already to the point where we're very likely to see an effect even if we were to continue, and therefore it becomes unethical to continue. So this trial was stopped early. So those are the two. So Chris, give me your take on this study. Good study?
Yeah, I think it was a terrific study, actually. It was, methodologically, it was very rigorous. The blinding, the randomization were, as far as I could tell, very well executed. The study protocols were adhered to exquisitely, and the choice of endpoints really left very little room for, subjective interpretation. I mean, dead or not dead is you can't really spin that in any significant way. So I thought it was a really powerful study, and it also comes on the heels of a whole series of similar clinical studies with pembrolizumab that have similarly shown profoundly effective results. And I want to make a couple points about this. And the first one I think that is really fascinating about this drug is that this compound is the first time the Food and Drug Administration has ever approved any drug for cancer based on the presence or absence of a genetic marker. That is to say that they're looking to see what is the particular mutation that exists that allows this cancer to thrive and to evade the immune system. Typically, when you look at any other cancer drug, you'll say this drug is indicated for the treatment of head and neck squamous cell carcinoma or liver cancer caused by Merkel cells, or intestinal cancer caused by Merkel cells, or squamous cell cancer, or basal cell cancer, or melanoma,
or whatever.
Whatever. All of the for whatever. But they're all looking at something on a microscope slide from some tissue. This organ, this kind of cancer in this organ, and that's how chemotherapies have been tested and approved. And for this one, the FDA has thrown that model completely out of the window and said you can use this agent for any cancer, no matter what it is, leukemia, solid tumor, doesn't matter, so long as this biological marker is present, because it will work, because we are turning off a universal switch that affects cancer pathogenesis. And that is, to say that's a paradigm shift is to really put to try to minimize this. This is a thunderclap in terms of oncology.
Wow.
Yeah, no, it's true.
It's a huge change.
It's been shown to be miraculous in myeloma.
Yeah, I mean, I was going through the literature on this. So this product, this pembrolizumab monoclonal antibody, has been used for head and neck cancers, for melanomas, for Hodgkin's disease, for advanced renal cell carcinoma, gastric cancer, throat cancer. Right. And in each case, it has performed extremely well. And in fact, when you're looking through the discussion narrative here, they kind of hint at this evolution in treatment paradigm. So you start with the inclusion of pembrolizumab as an adjunct to second-line therapy if first-line therapy has failed. And so,
which, by the way, presumably is the reason why they allowed crossover in this study, was because if you're failing first-line therapy, this is the drug that you would go on to as second-line therapy, and therefore you have to allow people to cross over.
But one of the things that the authors do say is that in this particular kind of cancer, if you start first-line therapy, oftentimes it progresses so quickly that you become so debilitated that there's not enough time to go to second-line therapy, which is another reason why this is actually very exciting for this particular kind of cancer.
Which is also probably why the allowing people to switch to the people in the control arm to switch to essentially the intervention probably made very little difference. Even though essentially what you're doing is you're allowing people in the control arm to get the intervention, which normally would bias towards the null.
Right.
Probably didn't do that much, given what
because
you're saying.
Because it was a little bit late.
Because it was probably too late.
But still, one could make the argument that the effect size would have been even greater if, in fact, that had not happened.
You could.
Yeah.
So let me just regather the thread here. So we started with this paradigm of adding pembrolizumab to second line therapy in cases where first line therapy traditional chemotherapy had failed. Now we've gone beyond that. Now we're saying, okay, well, let's put pembrolizumab right into first line therapy to see does that make a difference. In the case of the study, unambiguously, it made a huge difference. It cut mortality in half, for goodness sakes. But now, the movement is towards, do we need chemotherapy at all? Can can we just use pembrolizumab and get rid of all the cytotoxicity? Is the cytotoxicity, the platinum and the pemetrexate, is it doing anything other than poisoning the patient? And maybe we could just use immunotherapy, full stop, which would be, again, like that is, the second thunderclap coming behind the first one.
But that's not been tested.
That is where this is going, however.
That's where we're headed.
That is where we're heading with this. And it is really astonishing.
Plus, there's other molecules that are being looked at besides PD-1 that might also be amenable to immunotherapy. Now, it's a monoclonal antibody. It's a protein, and one would think that it really shouldn't have very many side effects. It does seem to have fewer side effects than standard chemotherapy, and I think everybody's familiar with really all the awful side effects of standard chemotherapy. But there are a small number of people who, in fact, do have very serious side effects from this kind of immunotherapy. And I think there was an article in the New York Times about 4 or 5 months ago indicating that sort of raising this idea that there are people that have sort of kind of prolonged hemodynamic instability. And
what does that look like?
The blood pressure sort of drops off, and they go into shock, and they have to go to the ICU. And it's a small number, but it's not a completely benign medication.
Absolutely not. But the kinds of toxicities that we're seeing are in some ways quite predictable based on the mechanism of action, which is to say that this is a monoclonal antibody that defeats an anti-inflammatory response.
Right.
Triggered by the cancer to
It's
turn off your
pro-inflammatory
lymphocyte.
in essence.
So it is a pro-inflammatory response, and it is this immune checkpoint point in pathogenesis that pembrolizumab is targeting is also important in controlling autoimmune diseases. So many of the side effects that they've seen are autoimmune diseases like type 1 diabetes or Hashimoto's thyroiditis or thyroid hyperexpression of thyroid toxicosis, we call it, hyperexpression of thyroid hormone, or damage to the adrenal glands or damage to the pancreas.
Keep going.
Pituitary.
Okay, don't keep going.
Damage to the pituitary gland, et cetera, and also fibrosis of the lung. All of these are autoimmune processes, and so we're seeing, again, as you're saying, like the science really lines up here. We know how this thing works, and it's behaving as it is. And in the current study, there were in fact a number of individuals, unfortunately, in the intervention arm who had pulmonary inflammation and died. There were none in the control group. So, this is not a benign treatment. They had autoimmune reactions to their lungs, and they essentially suffocated. And it must have been a horrible death for them, unfortunately. Yeah. And yet, despite that serious side effect, the aggregate benefit was so overwhelming in favor of this compound.
Yeah.
So, you guys both sound like you're fanboys here. Big supporters of this. Anything concern you when you read this trial? I mean, so one of the things that I couldn't really sort out is as you said, the side effect data, because virtually everyone had some kind of. I was trying to look at the numbers and I've lost it now. 99% had
something,
an adverse event.
Well,
but
that's typical.
That's typical in the case, and obviously
because they also all got chemotherapy.
And you're also weighing the scenario where. We're talking about survival. Survival is obviously the number one thing we're trying to establish here. But I was just curious. I mean, is there any indication that the side effects are worse in the immunotherapy? They did seem to be, but
yeah, I mean, there were more side effects in the intervention group than in the control group. But remember, both of them got the same backbone therapy of chemotherapy.
Yep.
So you're adding on the additional side effects due to pembrolizumab beyond what you would expect as the basal rate from the other two drugs.
Yep, and it did seem like both arms experienced adverse events at similar rates, although it was definitely increased in the intervention arm. I had a little bit of concern, not huge concern, but I mean, so this was a double-blind study, as you say, hard endpoint, unlike the antidepressant trials that we've looked at, that would be much harder to manipulate. The blinding seemed to, from what we could tell, have worked. There was, as Don pointed out, some imbalance. So 600 people randomized. There was a 10% absolute difference in the percentage of men, which seems a little odd and like something you might want to actually control for. The second thing that does give me a little bit of pause is the fact that this study was stopped early. Mm-hmm. And this is not a criticism of the authors of the study, but generally when studies are stopped early, we tend to overestimate effects. And so, Don, your point about the non-differential misclassification maybe biasing towards the null, possibly, certainly, but I'm more concerned about the bias, the overstating of effects that potentially happens whenever we stop a trial early. And so, it's not clear to me that we would expect to see such large effect sizes when this went into usual care. So those were sort of my two criticisms, and then those are, all in all, those aren't huge criticisms. I have one other concern, which I'm curious your take on, which is the study was funded by Merck. And in particular,
which is the manufacturer.
Merck is the manufacturer of the product. The study specifically says, and this is not surprising, the investigators agreed to keep all aspects of the trial confidential. And we have been looking at trials over the past couple of weeks in which there have been concerns when there is a drug company funding a trial. Is it fair for me to have some skepticism just simply based on the funder, not based on what I'm reading, not based on the quality of the science that I'm trying to assess, just based on the fact that, looking at previous studies that have been funded by drug companies, things looked okay, but we later found out that there was some manipulation going on.
Yeah. Well, I think I've said this. I said this on a previous podcast, that the question is not whether there's a conflict of interest. There is.
There is.
But how do we mitigate the conflict of interest and protect the validity of the study?
Yep.
And so I guess I would start by saying I was impressed in that same section that you just quoted from, that they had that section where they went into the description of this is a study that was sponsored by Merck, but then they went into who had access to the data, who analyzed the data, who wrote the paper, and that I have very rarely seen that degree of transparency and disclosure.
Surprised by the extent of it. I agree.
I was impressed by it. In fact, I thought it was a good sign. I don't know whether they came from the journal or whether they came from the sponsor.
Hard to know. Yeah.
Kudos to them for that.
Very specifically with respect to the last podcast where we were talking about that, in this paper they say all the authors attest that the trial was conducted in accordance with the protocol and all its amendments and with good clinical practice standards.
Yeah.
Yeah, I don't know exactly how much.
It sounds good. I did not look at the protocol. Did either of you?
No.
Yeah, I think that would be one thing of interest. They stated there's reason to believe it, but there's also reason to be a little bit skeptical.
Yep. Okay. So in other words, there's nothing specific I'm going on here. There's no specific concern I'm getting at. It's just when I know there's a conflict of interest like that, it is impossible for me not to weigh that in somewhat, given all the evidence we've looked at in these past 23 podcasts or so when there has been a sponsor involved.
We've been burned before.
Yeah.
And the remedy is for this to be replicated by an independent group.
Right. And for us to see what goes on when this is starting to be used in usual care. The last point I want to raise is this issue of the fact that the study did better. The effect size was greater for females than males.
Fascinating, yeah. That really stuck out because those two confidence intervals, point estimates and confidence intervals on their figure diverge so strikingly.
Yeah. So
Why
the effect
women
size
so much
was
better than men?
Well, the effect size was 0.29, relative effect size 0.29 in women and 0.7 in men. So if you believe that's true, this is a drug that's going to work better in women than in men. The sample size was smaller slightly smaller, and there were fewer women than men, and the total number of events was fewer in women than men. Right. Which is to say, I'm not convinced, and the reason I'm not convinced is these are relative comparisons, and to me. And many people dispute this, but to me, when you're looking for differences in effect sizes, you want to look on the absolute scale, not the relative scale. If there is just less mortality among women, then the effect size doesn't have to. The relative effect size can be a smaller or similar absolute difference than it was in men, and we would only know that if they had given us the data to be able to do the absolute comparison ourselves. And that's just one of my pet peeves in life. Yeah. When the data isn't presented. In a way that I can make the comparison any way I want, they've only given me the relative comparison. So I'm not buying this until I see the actual data that tells me whether this is meaningful or not.
Well, I would hope that they're planning on a follow-up exploratory follow-up analysis, trying to understand, what are the factors that accounted for the improved survival of women over men. Like, were they on average younger? Did they have lower, disability scores?
Yep.
Did they have different kinds of tumors because of different smoking histories? I mean, there are many reasons why the cancers, because could have differed, because the primary driver of cancer is cigarette smoking, and the epidemiology of cigarette smoking in women and men is not the same.
Yep.
So there may be some biological tumor differences as well as differences in the health of the individuals.
Absolutely, but to me, the simplest way, I wouldn't even worry about going that far until I'd first just seen not whether you divide these two numbers, but whether you subtract them. Do they look dramatically different? And if they don't, then I'm not sure I would even necessarily pursue it. Anyway, anyone want a last word on this?
Well, I wanted to point out one limitation and one kind of curb your enthusiasm caution here. So the limitation is that nearly all of the participants in this trial had what's called an ECOG score of 0 or 1.
ECOG?
This is a scale that measures how impaired they are health-wise at the start of the trial. So a 0 would mean not at all impaired. And most individuals in all of the individuals in this trial were a 0 or 1, meaning that they were very healthy when they went into this clinical protocol.
And yet the mortality rate is massive.
And the mortality is massive. But remember that in a lot of patients with lung cancer, they are not healthy. And so one needs to be a little bit circumspect and recognize that in real life practice, things may not go so well.
Isn't that different from what we normally see in clinical trials, where typically patients who are in clinical trials are healthier on average than the typical patient with the condition?
That's right. So here they were unusually healthy for patients with lung cancer. Let's put it that way.
Yep.
Especially metastatic lung cancer.
Metastatic lung cancer. And the other thing it goes to the very last figure in this graph, which is looking at the overall tumor progression, free survival in the paper. And the pembrolizumab group, is outperforming the chemotherapy-only group all the way through. But the curves keep going down and down and down and down and down. There's no plateau, meaning that there was no point where the data suggested that any of these individuals were actually cured. So that death was the final outcome in almost all of these individuals, one has to assume. So when the newspapers are saying this is a miracle cure,
it's not.
They're not cured, but what is doing is buying them a valuable quality of life time.
Quality of life? Do we know that it's quality?
Well, I would think so, because the pembrolizumab is relatively non-toxic. So, but you raise a good point. I'm assuming that, but I don't know that from these data.
I think we don't know that.
Yeah.
Okay,
but Chris, you were addressing the not the overall survival, because the overall survival does appear to plateau.
Right, but I'm talking about But here you're censoring all the data. So in the first figure, we kind of lose all ability to really discriminate after a certain point because the numbers have gotten so skinny.
It's hard to say. It's pretty hard to say.
You see, the curves are just going down, down, down.
I think the follow-up for the study will be really, really important.
Yep.
What is the 5-year survival?
Right,
what is the 10-year survival due to pembrolizumab?
Yeah.
And how long can you sustain this? Is this a drug that you can take for years to keep your cancer in remission? Many questions to be answered.
All right, we got to move on. So let's switch gears in our second segment topic. And we want to talk about a controversy. It's not totally new, but we still thought it was worth getting into, which is something that came up in the cardiology world. And this came to us through an article by Larry Houston in...
Not Sam?
No, Larry. In Cardio Brief. The title of the article was "Cardiology World Erupts into Controversy Over Change in Major Clinical Trial." And there was indeed a controversy, although it may in fact have been a bit of an overblown controversy. And the general story is this, that there is a clinical trial that is going on. Someone else is going to have to describe the specifics of the trial if we need it, called the ischemia trial.
Ischemia, yes.
Ischemia. What's wrong with the way I pronounced it?
Ischemia?
Yeah. Ischemia.
We're all scheming here.
Okay, the ischemia trial.
Ischemia trial.
Which ischemia?
Yeah, you have to put the.
You sound like a late night radio host. Ischemia trial.
Ischemia.
And the issue that came up was there was a change to the primary endpoint in this trial that appeared in the clinicaltrials.gov, so the online registry where clinical trials are registered, very, very late in the trial. I mean, I think sort of as all participants were roughly enrolled, the endpoint was changed from a very hard endpoint, which was what, mortality and
heart attack, documented heart attack,
and heart attacks, to what did they change it to?
Unstable angina was added in, as well as...
I'm sorry, what's that word?
Unstable angina.
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 Yes. Got it, angina. And these are softer endpoints. These are harder to measure and theoretically lead you to a less clear outcome.
Right.
Now, the controversy erupted largely because there was a perception that change was made last minute.
Yes.
That this was sort of snuck in under the radar. And the reason for the change largely had to do with the fact that they were not able to enroll as many patients into their trial as they had planned. So they were planning for, I think, somewhere around 8,000 patients. They only got 5,000 patients into this trial because people are actually quite concerned. Doctors were concerned that the standard of care needs to be followed and weren't willing to refer their patients to the study. So they weren't able to enroll as many patients. Therefore, you need more outcomes. And the way you do that is by changing your outcome to something that is more common. So they included these less hard endpoints, let's just say.
I think they were also trying to address what they thought was a weakness of a prior study called the Courage trial, where they did use these soft outcomes. And found no effect.
Yep.
With respect to stenting.
Yep.
And they were trying to firm up the methodology to see if there was a real benefit by producing these hard outcomes.
Yep. Now, it turned out that the controversy was probably overblown because, in fact, the decision to change the endpoint had been made much earlier. So this was not like a manipulation that happened. We looked at the data and didn't see anything, so let's change it and try something else and pretend we'd always been this was what we were going to look at. The decision had been made much earlier along in the process. It just hadn't made it into the clinical trials registry until late, but it was well documented that this change had happened earlier. So fair enough, maybe the controversy itself was overblown, but the question then becomes, when is it okay to change your endpoint? What is the process one needs to follow when one changes the endpoint, and why? What is the justification that makes it acceptable to do so? And when is it just fiddling around with your endpoints to get the answer that you want?
I don't recall, but did they change the endpoint? Did they decide to change the endpoint after they unblinded the study?
I don't know the answer to that.
I don't think it says it in this article.
I thought
I'm going to say no.
That would be pretty egregious.
I don't know for sure, but I'm going to say I don't. I'm going to say my working assumption is that they didn't, but somebody will let us know if I'm wrong.
Yeah.
Chris, what's your take here?
Oh, it is a dangerous thicket of thorns that one wades into when you're changing endpoints in a trial. In fairness, it sounds like the authors of the ischemia trial had very little choice because they were going to have enrolled 5,000 out of their 8,000 or 9,000, planned participants in this trial, and yet statistically they could, you can, even without looking at the analysis, you can guess that you are not going to reach your statistical significance, and your trial is going to fail just because it's underpowered. And so you're stuck with a hard choice now. Like, what do? You either say, well, we've wasted our time with 5,000 participants and come up with no useful answer, or we have to modify our protocol so that we can, salvage some scientific value out of this tremendous investigation. It must have cost millions of dollars to do this thing.
Oh, I think it was like 80-something million.
Yeah, like preposterous amounts of
money. I
money.
may have made that number up, but I thought that's what I read. We're
some
talking like
ridiculous amount of money. I'm sure it was, it blew the bank to do this. And to sort of walk away with that with nothing really at the end of that would have been intolerable.
Okay, I'm going to fight you on that one, but go ahead.
Okay. I'm curious to hear what you think, but I think they were a little bit backed in a corner. What I think they didn't do very well was to message this.
Sure. It was poorly messaged.
Yeah, they could have kind of did it in the middle of the night, sent they're flunking off to update clinicaltrials.gov without telling anyone. And then it would just happen to be this other group of cardiologists were, trolling CTG, and they saw, hey, the ischemia guys have changed their primary endpoint without telling us all.
Yeah, I should say they were not trolling clinicaltrials.gov. What happened was they were writing a different paper. They were writing a paper about the impact of blinding on these trials, and the fact that if you don't blind these trials, there's very easy ways that these can be manipulated unintentionally. And so they were using the previous trials, the Courage trial that you mentioned, as examples, and they were sort of pointing to this ischemia trial as being better because it had these hard endpoints.
Right. And then suddenly they negated that by adding the soft endpoints.
They looked at this to finish off their paper and noticed, oh, wait a minute, something's happened here. So I don't think there was sort of, nobody was trolling them or trying to get them into trouble. It just sort of was a coincidence.
I don't mean trolling and like sending nasty emails to people on the web. I mean like trolling as in like looking at data. Yeah. So
what's your take?
Yeah,
because you winced.
This makes me very uncomfortable.
You get hives. You're itching. I can see you're itching right now.
Yeah, scratching, Matt. I'm scratching.
You're scratching.
You can't see itching.
What's the difference between itching and scratching?
Scratching is what you do for an itch. An itch is a sensation.
Itching is a sensation.
I wrote the Itchy and Scratchy show. I know. That's all I know.
You got to do both.
It made me very uncomfortable, this study, because it's sort of like
you can't see an itch. Come on,
you can't itch a scratch. You can scratch an itch. Come on, let's get it right.
I can see an itch.
Give him an itch. He takes a mile.
Not go.
Delayed reaction there.
Itch.
God.
Don, do you have any serious things to contribute to this conversation?
No, nothing. No, it made me very uncomfortable because it's sort of like manipulating your sample size, and it just seems to me to be not rigorous. And to change the goalposts after the game has started is just not fair. It's specifically when this study was designed categorically to try to address the issues in the prior study. So I think that no matter how much it costs, it's a waste of money, because what they probably should have done is they probably should have just gotten somehow some supplementary funding to enroll the full 5,000 rather than
8,000.
8,000 rather than just bail at 5 and pick different outcomes and say, well, we're done. It works.
But if it cost $84 million to get 5,000. What's it going to cost? I mean, it's going to cost a lot.
It's going to cost a lot. It's going to cost more, but you're going to have a definitive, rigorous answer to the question that was not adequately answered with the prior study. So now you've spent $80 million or whatever it is, and you've not improved our knowledge that was obtained with the prior study.
Particularly in light of that study we reviewed a few episodes ago, the Orbita trial, where they did the placebo acupuncture for stable angina versus.
Did you just say acupuncture?
He did.
Did I say acupuncture? I did. Oh dear.
They did not do.
Well, we're hoping it was an accurate puncture. So they did placebo stenting versus actual stenting, and found that the patients could not tell the difference between who got the stents and didn't get the stents. Neither could their doctors.
Yes.
So so the placebo effect in stent research turns out to be really powerful.
Yeah.
And the guy who wrote that article actually is the same one who blew the whistle in his editorial on this ischemia study.
Exactly.
So he obviously had that paradigm, hardened in his mind that we need to be really careful about these soft endpoints.
Go back to the stent podcast that we did if you want any more background on this, because it's intimately related.
Around there.
Okay, can I tell you guys why you're all wrong?
Okay, yeah, let's hear it.
Okay, no, I don't think you're wrong. I actually agree with what a lot of you both said, and I do. I mean, you've sunk a lot of money into this, and you theoretically you want to get the best possible answer, which means going getting the full 8,000 and really finding the answer. But I do think that
some people say that everything that happens after the but is BS.
Oh, Donald, shame on you. Anyway,
I hate
but I do think so much of the reason we're in this problem is because of this deification of statistical significance. And that we could do both here.
This is the Matt Fox hobby horse.
It is. And I'm going to ride this all day long. There is no reason we can't do both here. There's no reason we couldn't have come out and said, we're not going to get our desired sample size. We're not going to be able to definitively, I don't know if that's the right word. I don't think that's the right word. Definitively answer the question of death and heart attacks based simply on a statistical significance criteria.
Yeah.
But we are going to learn a lot of really valuable information. Maybe we don't quite reach statistical significance, but that's the point at which we have to use reason as opposed to just statistical significance to draw inferences from the data that we have and not pretend like we learned nothing from an underpowered study just because it was designed to answer a particular question a certain way, and we couldn't do it.
So we need to, basically you're saying we need to be a little more thinking and more nuanced and less categorical.
I do. Now, that doesn't mean we say at the end of this, if we find there's a benefit to, one arm versus the other, but it wasn't statistically significant, we say, aha, we've answered the question. We should never say that based on the results of a single study, but we should say this is some evidence. It's not as strong as it would have been with the bigger study, but we have more evidence, and not act like we have no evidence just because we didn't reach statistical significance. And that's where I just get really, really hung up on this idea that statistical significance is poisoning our ability to think for ourselves.
Mm-hmm. Yeah.
And it really bothers me.
Agreed.
I agree.
Agreed. But in this particular instance, this particular study was created and designed specifically to address issues like you're speaking about with regard to the prior study. So I think in general...
But they're still doing it. I think they're still doing the same thing. They're just not going to get the sample size that you would have ideally wanted. You can still have that primary outcome and draw inferences and say, look, we know...
You'll have an effect. It might not be statistically significant.
But look, this looks encouraging, or this is, and we're never, ever... If they couldn't do it, nobody ever can. It can never be done. Because this is our best hope to ever get the sample size.
But they threw in the towel halfway through.
No, I'm saying, so no one's ever good. This is the best possible hope. No one else is ever going to do this study later again and try and repeat this. But let's take the data with the best information we have. Let's combine it with everything else we know, and let's draw reasonable inferences.
And of course, if that was the approach they took, I guess that is the approach they took. They didn't really lose anything in that interim analysis consideration, because they still have the hard outcomes. They can still analyze that the way it was originally intended, plus the inclusion of the softer endpoints, and then appropriately caveat that in their limitation section.
Exactly. Just do both. Be upfront about the reasons that you're doing it, and draw reasonable inferences.
I wouldn't also wonder if this would have been a perfect opportunity for a DSMB to do an interim analysis around this and give
utility assessment,
essentially, or give the investigators some reason to sort of say, are you able to, with your current design, deliver a reasonable answer? And maybe they did that, maybe they don't know. I just wonder if that
I think the answer is probably going to be no, given they were underpowered, unless they had a bigger effect. And I wouldn't want to stop this study early. It just seems like we want to know.
It's another kettle of worms, I suppose.
All right, early. Well, let's leave it there. That one was quite a bit more heated than I thought it was going to be. Let's move to our amazing and amusing. So this is our last segment where we want to highlight some of the things that make us just laugh out loud or enjoy our jobs even more and look at the amazing things that go on in this world of science. Chris, what do you got for us?
Nothing of any interest, apparently. Very boring stuff. I found this article in the journal PNAS, Proceedings of the National Academies of Sciences.
Got it.
Right? About, it's entitled Nouns Slow Down Speech Across Structurally and Culturally Diverse Languages.
Nouns are the breaks.
Nouns are the breaks in speech. And that's basically the theme of this article. And they did it using a very clever set of analyses where they taped people in 9 different languages to see if this is a universal effect. And then they looked at the grammatical constructs in their sentences and measured the amount of time that people spent trying to state a word as opposed to when they would delay coming up with the next word. And they found that the time to generate a noun versus a verb was statistically longer across almost all 9 languages, and that the amount of pauses you put before stating a new word that was a noun was much longer than when you had a pause before a verb. And the kind of fascinating thing about this is that, English, for example, has a very large vocabulary. So there's it's hard to count them because what is teriyaki an English word or a Japanese word? This is, where do we draw the boundaries between our language and words that have been appropriated? But generally we think that English has about 500,000 words in it. And of those, 2/3 of the words are nouns. And about a quarter of them are adjectives, and the rest is everything else. And so verbs are actually a very small number. So there's a very few, there's a relatively small numbers of things that you can do, that is to say verbs, as opposed to the numbers of things that you can name, which is almost infinite. And so
that's really
it's kind of
interesting.
like random access memory, where the brain has to like sort of pull in these things which are used very rarely, which are nouns, and pull them down into a sentence structure, and that takes time, processing time. And that's what they've shown. And they've shown this is basically a universal effect across all languages.
That's pretty cool.
It was very cool. It was very cool. Yeah. So that was, I think, a neat article. So it is. Seifert and colleagues, again in PNAS, noun slowdown speech across structurally and culturally diverse languages.
Really
PNAS,
cool.
20 recent.
20 recent.
20 recent. I can't see the date on his
I've
name.
been there.
2018. So
Very cool.
Just came out.
All right. Well, I'm going to go next. Don will leave you for last. And I've got an article here from the BMJ. It is from September of 2016. Accepted in September. This was published in their December edition. And the title of the article, this is from Andrew Gray and colleagues. The title of the article is "We Read Spamalot. Prospective cohort study of..."
Wasn't that a musical?
It was.
It was so funny.
I've never seen it, but I would like to. "We Read Spamalot, a prospective cohort study of unsolicited and unwanted academic invitations." So we've spent a lot of time on the podcast talking about these invitations that we get to be reviewers or to submit articles to journals that are not in our field, or say, "We really enjoyed your publication," quote, nothing in between, things like that. So these folks got pretty annoyed.
Dear Dr. Gill, CJ.
Dr. Gill CJ, yep. These guys got pretty annoyed, and so they got together and looked at how many of them they were getting, and then tried an intervention to try and reduce them. So this was, in the abstract, it says, the objective was to assess the amount, relevance, content, and suppressibility of academic electronic spam invitations to attend conferences or submit manuscripts. The participants were 5 intrepid academics and a great many publishers, editors, and conference organizers. And the main outcomes were the number of spam invitations received before, immediately after, and 1 year after unsubscribing from senders' distribution lists. Okay. And they found, so they said the inclusion criteria were personal acquaintance with the first author, a sense of humor, a relentless wish to conduct leading edge research, desperation for academic output, and an inability to say no. One person, of course, had to be excluded because they had an ability to say no. And then they went and they conducted this experiment. They have a nice table here in which they list each of the 5 members, and they list their number of research years experience, publications at the end of 2013, presentations in 2013, and their height of esteem based on the height of esteem referenced in the spam letters that they were getting. So they were often referred to as most esteemed.
Somewhat esteemed.
Turns out they are all highly esteemed.
Oh, really?
Yes.
Oh, it's not just me?
And what they found was that they get an average of 312 calendar month. Each calendar month, they were getting an average of 312 spam invitations. And that after they unsubscribed from as many of them that would allow them to, the number of spams that they got went down, and then a year later went right back up. Not to where it had started, but went way back up. And they give some examples of the spam that they were getting. They categorized them into friendly and exuberant, aspirational and dedicated, and thematic. So some of the friendly and exuberant ones would be, "We would really be happy to anchor with you." Don't know what that means. "Let your wisdom enkindle others. Looking forward to an everlasting scientific relationship. We have been through your articles and we are enthralled to know about your reputation and commitment in the field." So I just thought that was a nice use of an actual pre-post intervention study on something that we care deeply about.
So what was the magnitude of the effect? Like how much could they drive the spam levels down?
Yeah. Well, I don't know that it was that much, largely because not many of them have an unsubscribe button. But it went from about 350, let's say, down to about 200 and then back up to under 300. So they definitely had an effect.
I think they were all Russian bots.
Could be. Could be. All right, Don, what mature thing do you have for us this time?
Well, I'd like to just register a complaint.
Okay, what would you like to...
Because the listeners don't realize that there are 2 really important studies that I have found to be very entertaining, and Matt has prevented me.
No.
Because you were not able to
Keep a straight face.
Keep a straight face.
It is true. So the listeners are aware, at least so far, 2 of Don's weird, wacky science, as he calls it, have been nixed from the program due to my inability to keep a straight face. I will agree with that.
Right. So, unfortunately, I'm having to go to my B pile.
The B pile.
Right,
Okay,
which
give
I'm
it to us.
not that happy about.
I'm
so anyway,
sorry about that.
Here's a study that was published in Consciousness and Cognition.
Yep, which we read all the time.
Right, which is entitled by Marina Di Tommaso, Michelle Sardaro, and Paola Lavria from Bari, Italy.
Yep.
Entitled "Aesthetic Value of Paintings Affects Pain Thresholds."
Oh, okay, yeah.
So what they did, I don't know how, since I haven't really read it carefully because my first study was next. But basically, what they did is they found 12 healthy volunteers who graded specific images in terms of how beautiful they were, paintings and photographs and stuff like that. And that each of those 12 healthy volunteers had a gradation in terms of the images that they had previously graded. And they were then given an external stimuli, which was laser pulses to the left hand.
What now?
Measured to induce pain. And so the pain
sounds
that was
mean.
the sensation of pain that they experienced by having a laser be pointed at their left hand was modulated by the quality of the image in which they had previously graded in their estimation. So
why can we
watching
not get paid
beautiful
to do stuff like
paintings,
this?
watching beautiful paintings or photographs diminished the pain that they experienced when they had a laser
So
Zapping them.
zapping their left hand.
by analogy, could this be made worse by looking at ugly paintings?
That's the obvious follow-up
I mean,
study.
that needs to be done.
Yeah.
Wow.
And how did they objectively define beautiful versus crappy paintings?
It didn't matter because it was all in the eye of the beholder.
So they self-said, like,
Correct.
this is a beautiful painting.
Correct.
And then they're like,
Correct.
I don't even notice that my
Right, so
left
each 12
thumb
went-
has got a little curl of smoke coming out of it.
I wouldn't say that they didn't notice.
It's like, I don't mind that my hand,
Wow,
the
this
hairs have been
Renoir.
just removed from my
This
forearm.
Renoir has really changed my opinion on
Wow,
being
that
okay.
is...
But
that-
let me say that the study that was nixed was a much better study and would have been much more of interest to the listening.
All we can say is that it had something vaguely to do with guys in bicycle shorts, and we'll just leave it at that.
All right. Well, we're at the end of the program. If you've got any feedback on this or any other episode, or you want to suggest a study or a topic for us to take on, you can tweet us at @PopHealthyX, or tweet me at ProfMattFox, or Chris at ID.Gill, or Don at DTheo1. You can find us on the Population Health Exchange website at www.pophealthyx.org. We want to thank Leslie Talalian, Director of Lifelong Learning at BU School of Public Health, for supporting the podcast, and Nick Guler for sound and editing. Did you notice I had to pause there before the nouns?
Yes, you
I
did.
did. So thanks.
0.15 milliseconds on average.
Thanks for joining us. We hope you enjoyed it, and we hope you will download our next episode. Then cue the music. Do 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 do.